I wasn't planning on doing the introduction, but I'll do an introduction. Alex has convinced me to do an introduction, so
I don't think that's
I'll do
on.
what's that?
Is that a mic?
It's a mic, yes.
It's not on.
It's only connected to to my phone.
Oh.
Yeah.
Oh, okay.
Yeah.
I'll do my best to do an off-the-cuff introduction. So my name is John Dooley. I am the owner and founder of Greendale Physical Therapy, where you don't have to be an Olympic athlete to be treated like one. We've got 6 locations in the Central Mass and Worcester area, including Neurological Balance and Vestibular Center here in Worcester, and our Sports and Orthopedic Center right here that we're in. We have over 35 awesome therapists that work with Greendale Physical Therapy, and we have a lot of specialties, whether it be vestibular, aquatics, dry needling, sports rehab. There's a lot of things that we do. Yeah, and I just wanted to give a quick history about this Worcester facility for some people who may not be familiar. Is we were across the street. We actually originally started at the Greendale Mall, moved to a facility, a 2,000 square foot facility next to Panera Bread across the street. We were there for about 10 years, outgrew the space, looked very hard for a space in Worcester, found a space right across the street, about 5,000 square feet. We converted the old 3,000 square feet into a first of its kind in Central Massachusetts Neurological Balance and Vestibular Center, and then we brought the sports and orthopedic aspect of the practice across the street to this 5,000 square foot. So we've got 8,000 square feet in Worcester for our patients, and we take good care of our patients. But anyway, without further ado, I want to introduce you to Nick Garagno, our occupational therapist. Just a quick thing about occupational therapy. One of our guiding principles is physical therapy. It's what we do. But recently, within the past year, we've added occupational therapy. So now we're changing it to physical therapy and occupational therapy is what we do. It's been a very nice addition to our services and for our patients. So without further ado, here's Nick Garagno.
Thank you.
Thank you, John. All right. Well, thank you everyone for showing up. My name is Nicholas Garagno. I'm an OTR. I just started here at Greendale about 6 months ago, and I'm excited to get the program going and see where it can end. All right. So just to kind of give a brief overview of what I'm going to be discussing, what I want to talk about is how occupational therapy in general, how it facilitates an individual in recovery. What are the responsibilities of an occupational therapist? What types of diagnoses that can be treated as an OT, and what environments an OT works in. And of course, what the lecture is about, like how occupational therapy is implemented in an outpatient sports medicine setting. And just a brief overview of who I am. Like I said, my name is Nicholas Garagno. I've been an OTR for about 2 years now. I first started as an assistant. I worked as an assistant for 5 years. I graduated from Quinn Sigmund Community College, got my associate's degree. Then during COVID, I went back and got my master's and became an OTR. I went to New England Institute of Technology. And I've been specializing in the sports medicine facility or setting for the past 7 years. So what is occupational therapy? So OT helps engage activities of daily living or activities in general. It promotes health and well-being through those activities to help people kind of get back into the routine of things. It supports participation in important life routines. So we try to get you back into doing what you enjoy doing, rather than just create a exercise-based rehab. And then it restores your function after illness or injury. And the goals of occupational therapy is to increase independence, improve your quality of life, restore function, promote participation in daily routines, and it does help support your mental, emotional, and physical well-being. So some of the OT therapy settings, Or like we can go to residents, or your residents, do some home health. We do work in hospital settings, school settings. We do skilled nursing facilities, primary care clinics, and of course the outpatient setting, which is starting to become a little bit more popular. As you can tell, there's not many OTs in an outpatient setting, which is why when John in Greendale gave me the opportunity to advocate for OT at a different outpatient setting, I couldn't help but kind of grow the field a little bit. And then these are some of the diagnoses that we treat as OTs. So some neurological conditions, strokes, traumatic brain injuries, concussions, cerebral palsy, MS or multiple sclerosis, Parkinson's disease. Some of the musculoskeletal or orthopedic conditions include like any kind of arthritis. Usually with OT, we try to limit it from the shoulder down to the fingers. So any arthritis of like your thumb, your finger joints, shoulder arthritis, anything like that. Fractures and dislocations, so if you break your wrist, fall down at home, fall down during like a sporting event, anything like that, and you fall on your hand and break your wrist, we'll treat that. Any amputations, if you end up having an accident with a saw, if you're a construction worker or anything like that, and cut off the tip of your finger, we do help with that. Any hand injuries, repetitive strain injuries, so anything with like tennis elbow or golfer's elbow or lateral medial epicondylitis, carpal tunnel, cubital tunnel, anything like that. And then any kind of joint replacements. So a lot of times I see people that get thumb arthroplasties, or they get the thumb or the CMC of their thumb replaced or taken out. So what we try to do is basically improve the strength and the functionality of that thumb again. Some more diagnoses are any geriatric conditions, so dementia, Alzheimer's disease, fall risk or balance issues, and of course vision loss. And then work-related injuries. Again, repetitive stress injuries, any burnout, stress-related disorders, ergonomics, which is a big one, especially nowadays with technology. A lot of people have poor ergonomics and end up with either neck pain, carpal tunnel, poor body mechanics in general. And then, of course, going back to the sports medicine, occupational therapy. So here we try to focus on more of the orthopedic stuff or like neurological things. I will work, like I said, from the shoulder down to the fingers if you have any kind of acute or chronic shoulder injuries, arthritis, if you have had a stroke in the past, if you've had a concussion, I do work on your vision, as well as any kind of cognitive disabilities. And I do also fabricate orthoses or splints. So if you've had a stroke and you either have poor tone, which you can't move anything at all, or if you're spastic and your arm or your wrist are tight and too tight that you can't move, I do fabricate splints to allow you to either go into a more neutral position, which allows one part of your muscles to tighten up a little bit while the other ones can relax and allow you to be a little bit more functional with your hand. And discuss it, or brief discussion about splints is, like I said, I can fabricate splints for various diagnoses, either promoting immobilization after like a surgery where most of the doctors don't want you moving, and it's a lot more comfortable than being stuck in a cast, because you can remove it and it's a little bit more lightweight. And these are some of the examples that I do create. There's either like hand-based thumb spikas, so if you have arthritis in your thumb, that's usually a good one, or a stroke where you can't lift your thumb up, it kind of puts your thumb in a good placement. There's long thumb or forearm-based thumb spikas, which if you have any kind of tenosynovitis, or it's called Dacre veins or thumb tendonitis, this helps immobilize it to allow for healing. There are wrist cock-ups, which allow for any kind of distal radius fractures or wrist fractures. There's finger splints they're called mallet fingers or swan necks. A lot of times they're also called jersey fingers. If you're playing football and you tend to grab someone's jersey, you tend to rupture the tendon at the end of your finger, and then it droops. So those splints help kind of tighten it back up so we can try to avoid surgery. There are Munster orthoses, which if you're having any kind of wrist ligament or tendon injury, it keeps you from rotating, which would further injure that area. And then there are long arm orthoses. So if you've had a cubital tunnel release or any kind of surgery like that, or an elbow fracture, it keeps you in a position for healing. And I did bring some that I fabricated in the past that if people want to look at it, you can. Or if you want to pass them around, I'll bring this one over here. So that one's a Munster. That was made on my arm, so it's a little bit bigger. But these are the types of splints that I usually will make for people. They're not always the most comfortable thing, but it does get the job done. And then what do I do here at Greendale, and what kind of diagnoses do I treat? So this is a list of things that I personally treat here. Like I said, whether it be carpal tunnel, distal radius fractures, Dupuytren's contractures, Dacre veins, hand weakness, mallet fingers, swan necks, TFC injuries, trigger fingers.
What's TFC?
So TFC is you have a ligament that comes across into your wrist. So it attaches both your race and your ulnar bones and allow with rotation. So the Munster orthosis that's being passed around, it keeps you in a neutral position so you can't rotate anymore.
What does that stand for?
Triangular fibrocartilage ligament. So that's TFC. So that is usually a complex injury. That's usually an injury we don't want to kind of mess with, because if it gets worse or goes any further, sometimes they have to take the wrist bones out, sometimes they have to fuse your wrists. So if we can avoid it, we rather. If you're experiencing any trigger fingers, which is a repetitive injury, wrist tendonitis, and usually wrist drop if you've had any radial nerve issues. I do shoulder diagnoses, whether it's impingement or acute/chronic shoulder pains. The neurological diagnoses I treat personally are Parkinson's disease, strokes, concussions, and with concussions I usually do a lot of the vision stuff, while PT works on the vestibular system and walking with dizziness. I'll treat someone's eyes. So a lot of the times with concussions or strokes, with strokes, if you hit the back of your head, your vision is affected. The muscles in your eyes become weakened, and then we tend to use our necks a lot to compensate for it, and then end up with neck pain. So a lot of times OT and PT work very well together in kind of creating this better outcome for patients. And I've had the pleasure to work with a bunch of great PTs in this clinic that we kind of bounce ideas off of each other or discuss certain patients and how we can kind of like co-work with each other to create a better outcome. Cerebral palsy and traumatic brain injuries. And then of course the elbow diagnoses, lateral medial epicondylitis or tennis and golfer's elbow, cubital tunnel syndrome, bicep tendonitis, tricep tendonitis, and then just some general diagnoses like arthritis and Ehlers-Danlos or hypermobility. And just with the conclusion, kind of going over everything of like how occupational therapy is highly diverse profession. OTs and PTs often collaborate closely and work very well together. I know, like I said, I'm trying to advocate for OT because PT's been around a lot longer, so everyone assumes any kind of rehab is PT. I've worked with some hand therapists or some hand doctors in the past that still think we're PT. But all we can do is advocate and kind of teach people what we do as a profession. And the profession may practice in various settings, including outpatient sports medicine clinics. And like I said, it's a growing practice for OT, and I'd like to continue growing it or have others continue to grow it, because I think OT can do a lot of good in this setting. And then, like I said, occupational therapists are also skilled in fabricating custom splints. And speaking of that, I was gonna make a splint for you guys just to kind of give you an idea on like what I do with it. So is anyone having any kind of thumb pain and want these splints?
I have wrist issues.
Well, it won't help your wrist as much, but if you want one for your thumb or any volunteers to make a splint on. Perfect. All right, so I'm just gonna heat this plastic up real quick and then I'll come out and I'll make it on your thumb. Are you able to come up here by any chance? I'm just gonna have you kind of rest your hand down, or whatever's comfortable for you. Let me know if this is too warm.
What is that material?
So it's called Polyflex, so it's a plastic. Yeah, that molds specifically to you. And then we'll cut it and kind of form it a little bit better.
So do you have to have tattoos to be an OT?
You can, it's optional.
Quite an arm sleeve there.
Oh, thank you.
Only the cool one.
Only.
Only the
Exactly. See, I knew I liked her.
OT is so versatile, so varied with, you do, cognitive, physical, all kinds of different aspects.
Yeah.
I didn't know you dealt with eyes and vision either.
Oh yeah.
That's
So
interesting. It's a very creative field too, because you have to think outside the box a lot, right, to help people accomplish their goals.
yeah. And like I said, PT and OT, we both try to create the best outcomes for everyone. And that's why I want everyone or more people to understand what OT does. So a lot of times people think we just work in skilled nursing facilities.
They're in schools a lot, aren't they?
And schools, yes. I'm just gonna keep this up. So, and this is a setting that I personally really like. And actually being in school, even my teachers told me that we were most likely never gonna be in this kind of setting. So, to be able to be here and kind of advocate for it is good. Because I'm sure there's other people that were in my position that would like to be in a more sports medicine facility.
Have you ever visited the Worcester State OT clinic?
I have not.
They have a good OT program.
That's what I've heard. I've had a couple of colleagues talk about it.
Where's your school? Was it in Boston?
My first one, it was down the street.
Well, I know.
Yeah,
the other
and my
one.
second one was in Rhode Island.
Rhode Island.
Yeah. Because with OT, if you start off as an assistant, they have something called a bridge program.
Uh-huh.
So you're able to get your bachelor's and your master's within 3 years.
3 years
Yeah, because it's an accelerated one.
for a bachelor's and a master's?
Yeah, so
Wow. That's
Um,
incredible.
yeah, so it was helpful.
I would think 5 years.
Luckily not.
That's amazing. It's good value.
Yeah. So while OT still has a master's, it's worth looking into. Because they are discussing about creating it into a doctorate degree.
I would like everything. Right?
Yeah, so
Business. Lots of PTs that are PPT. So it'll be DOT.
yep,
So
so
it'll be a dot.
It'll be a dot.
of course if I make any of these like in clinic, and I'm treating someone, I always ask like where it, if there's any kind of like pressure points, red marks, stuff like that, bring it in to a next session and they can always be like fit or adjusted, yeah. Because you won't really know how it feels until you're wearing it a lot longer than a couple minutes I have you wear it in the session. So you can still bring your fingers in and you can pinch down with the thumb. So if you bring your fingers in and then you can pinch down like this. So it keeps you from bending all the way down
Oh, I see.
because it's more of like a arthritis or like a stroke orthosis. If people's thumbs are stuck down from a stroke, it helps lift it back up into a neutral position. And with any kind of thumb arthritis, all that bending down aggravates the thumb joint.
Can you do a little Vanna White moment?
Yeah, I'll show you. So it's just velcroed around.
It looks like you could do that in your sleep.
Yeah, that
Yeah.
was like super
Yeah,
speedy.
right now, but
It started out
it's definitely
warm
tough at the start.
and flexible, but now it's hard.
Actually, I have a couple questions. When it comes to, you were talking about the vision stuff when it comes to concussions. What do you do with Parkinson's and Alzheimer's?
So usually with Parkinson's and Alzheimer's, I try to get some bigger like strength movements in, but if they are having like visual difficulties, I'll have some like eye exercises for them.
Okay.
Or if they're experiencing any cognitive issues,
Yeah.
I'll usually like perform like a slums test or a Minnesota
Okay.
cognitive assessment.
Yeah.
But usually it's a lot of strength-based stuff for the upper extremities.
Okay.
Yeah.
Interesting.
Any other questions about anything in general with OT or
Have you had any finger replacements? Have you seen any?
What?
of that?
finger replacements? No, I haven't experienced any of that. I've done the, like the amputations and like the joint removals, but no replacements. Usually with the arthroplasties, they'll like pull out your CMC joint and like shove your tendons in there to try to create a little bit of a joint, but other than that, no replacements. Yes.
My mother has Alzheimer's and she's been living at Eisenberg Assisted Living for the
Mhm.
past 8 years. And their new director is in OT
Oh, nice.
and the head of wellness is an OTA. And they just hired someone for the dementia floor that's an OT.
Oh, it's great to
So
hear.
there's 3
So, yeah.
OTs there.
Yeah, because usually with Alzheimer's, I mean, with the outpatients, we're limited. There's only so much I can do, especially depending on how progressed it is. Because if it is progressed too long, usually they'll have them in like an assisted living just for like safety precautions mainly. But with outpatient, if we could catch it early, I always tell people if you don't use something, you lose it. So same thing with Alzheimer's with your brain. If you're sitting in front of a TV and just kind of melting away, the Alzheimer's is going to progress quicker. So I try to teach people just to try to do some cognitive, either it's games or activities just to get your brain working. Because the more you just kind of sit around and do absolutely nothing, the quicker it progresses. So we try to at least slow the progression.
Yeah.
We're not going to stop Alzheimer's, but if we can slow it down, that's usually the goal.
Yeah, I think the routine in the activities and the socialization there has really helped her slow the progression.
Yeah, exactly. Rather than sitting at home and doing nothing. So yeah, that's good to hear. That's awesome.
Have you heard of Tipa Snow?
I have. I did learn about her in school. Yeah.
She's an OT who has a lot of training online. She's an expert in dementia care.
That's cool.
And she teaches a lot of communication strategies and how to deal with patients.
That's very helpful.
Yeah,
That's
her videos were interesting. Anything else? Yes.
Question, if you had, 3 diagnoses that you could treat all day, what are your favorite things to treat?
All day? Huh.
Top
All day, yeah.
Half today, top 3.
I do like anything in the elbow.
Elbow.
Yeah, just because it's.
You like tennis?
Well, I'm not a tennis player, but I do like the shoulder. I find the shoulder very interesting. I want to learn more about it as much as I can, because I feel like it is a complex joint and there's so much that is involved with it. And I do like working at like any kind of wrist fractures, mainly because I like to see the outcomes of it. Seeing someone either get hardware or just out of an orthosis and slowly see them get their function back is always pleasing to see. So those are probably the 3 I would like to do all day, every day. If I had to pick 3.
Weekends too?
You know, maybe not the weekends. Weekends are stretching it, but other than that, yeah.
So is there an overlap with shoulder between OT and PT?
I think there is, and that's where it's great to like work alongside with some of the PTs because we can kind of discuss about not stepping on each other's toes with certain things, because we do get like, yeah, we do get like shoulders and then necks issues, so they're very, very close, and sometimes the exercises are also close. So we try to communicate with one another just to make sure we're not doing something or I'm doing something that's gonna aggravate the neck progress, and that if they wanna work on something, it's not gonna aggravate the shoulder. But PT also works on the shoulder too, so it's good to even bounce ideas and get their opinions on what they think a good exercise is or how we can better the outcome together. So yeah.
So how would a PT address the shoulder and how would an OT address the shoulder?
So we kind of both address it the same. And especially now, PT is becoming, I think, more functional. I know in the past it was basically based on like strength training and everything like that, but I see plenty of my coworkers out here doing functional tasks with patients, which is great. I see them simulating bowling or like cleaning surfaces, trying to get their shoulder in flexion. So we do treat it the same. So at that point, it's just like, how quickly can we get someone in? Can we get them quicker with OT or PT? And then same thing, we just bounce ideas off of each other if we're stuck. So, anything else?
So would you say OT is more functionally oriented?
It started like that, but I don't think so. I think it all depends on the therapist. I think
Occupational.
yeah, so that's where it all started. OT first started off as like a mental health field, I think during World War II.
PTSD.
Yeah, and shell shock and all that, so it became more of like a mental health profession, and then it just slowly kind of progressed into more and more and more. And it was based on like function, like trying to get people back into doing their daily routines or get them back to work. And then of course PT was known as your strengthening, like sports injuries, stuff like that, trying to get people back on the field. But now I think both professions have grown, and they're teaching kind of the same idea of like, let's get people back to functioning as best as they can so they can live their life how it was before they got injured. So I think it does depend on the therapist nowadays. Some therapists like strength-based, some like more functional tasks. So
How would an OT address a mental health issue compared to like a psychologist? Or would you be more focused on functional activities?
yeah, so it's more functional activities. Like I don't do so much with the mental health here, but when I was in school, they did talk about like what are some activities we can do to just kind of get them thinking more positively. Like we don't diagnose or we don't prescribe medications, we don't do any of that, like that's not our field. But coming up with activities to like what upsets you, what makes you feel better, like trying to come up with like socialization activities, like getting them to participate with one another in certain activities so they're not isolated. So that's more of the mental health thing, but we don't treat that as much in outpatient. We're aware of people's mental health. Like if someone comes in with like schizophrenia or depression, anxiety, there's ways we just kind of work around it to make the patient as comfortable as possible while we're actually treating the underlying issue. Anything else? Yes.
I kind of asked you about this earlier, but work hardening, what exactly does that entail as a whole? Just curious about it.
Yeah, no, so
Work hardening.
Work hardening?
So trying to get people back into like their manual labor jobs. So in the past, I've done just more like strength-based stuff, like either seeing where they came, like if they're construction workers, mechanics, warehouse workers, anything like that. Try to simulate like lifting boxes, trying to get up to like 30, 40, 50 pounds. Walking a certain distance, like 50 feet, pulling a sled, almost like simulating like a pallet jack, anything like that. So it's more of just like, I think it's past like that therapy stage of like, let's get you to like 3 pounds with the wrist. And then once we can kind of graduate from that stage, it's like, okay, let's start actually lifting bigger and heavier things to get you back into lifting 30, 40 pounds at work. So we don't discharge you from here at 3 pounds and then you go back and lift a box that's 40 pounds and re-injure yourself. So that's kind of what I do for like any kind of work hardening stuff.
Does insurance cover one more than the other?
Not that I know
Do
of.
they favor one side or?
That I'm not 100% sure of. I think Sean, I think they kind of.
I think there's
Covered the
different,
same.
I think there's some different coverages between PT and OT, so it depends on your health insurance plan. But I think they're probably very comparable. There's probably some nuances there.
How does OT work in the school setting?
In the school. So in the school setting, usually the OTs will work with kids with either developmental diagnoses or autism, sensory disorders, if they have any kind of delay. So they'll work with like handwriting skills, how to kind of regulate their bodies in class, so they don't have to be taken out of class away from their peers, so they can work on kind of socialization and kind of completing the task at hand. Or they come up with like sensory-based strategies to allow the kids to sit in class without interrupting other classmates and still be able to perform their school tasks. Anything else?
Last question.
Yeah.
How many orthotic, or not orthotics, but orthoses do you usually fabricate in a day?
In a day, it varies. So sometimes like I'll eval someone, and they'll come in with just like wrist pain. So I have no idea what's going on until I like figure it out. And sometimes within the last minute, I try to make a splint the first day if I can, just because if I can immobilize them and let them heal for the next few days to a week, I'd rather try it. But it can vary from like 1 to 2 or sometimes none, because if I'm constantly seeing the same people, they've already made the splint. But I'd say I probably make like 6 or 7 a week. Yeah.
That's cool.
Do you need a diagnosis from a doctor before you begin a treatment plan?
Usually I prefer one, just because I like to know exactly what I'm treating, because I'm not allowed to diagnose anyone as a therapist, but getting a general idea, like if a doctor writes a wrist pain or anything like that, it usually at least gives me an idea of like where I'm going. Even if someone came in and said, I have wrist pain, but knowing that they got x-rays or MRIs or anything like that usually is helpful. Anything else? No one else said?
Thank you very much.
Thank you. Thank you, everyone.